Good evening. Our group will be conducting an informal debate that will consist of an in-depth discussion of what it means to ethically collaborate with other professionals across different disciplines when working in the field of applied behavior analysis. In addition, we will be considering the benefits as well as possible barriers to collaboration. We will begin our discussion by introducing each of the group members and explaining the individual roles. After talking over the elements of collaboration, we will end our exchange of views by contriving a hypothetical mock debate. Although we all come from various backgrounds of education and experience, we all agree on the importance of collaborating with other professionals in order to give our clients the most effective treatment. So I'll begin by introducing myself. Hello, everyone. My name is Sam Hinton. I will be serving as an introducer for our project. I live in South Bend, Indiana, and I am in my first semester of this program. I've been in RBT for 3 years in 2 different settings, a clinic and currently a school. Before that, I worked as an educational assistant for 1 year at a middle school. So although I did not practice ABA there, it started my journey into understanding children with developmental disabilities. My scope of competence is providing services for children with autism ages 2 to 10 years old. And at my place of work, my BCBA emphasizes compassionate care. So an important consideration to take into account when working with vulnerable children is to understand their trauma history and thereby ensure the behavior intervention plans will not further their distress. One of my goals as a professional in this field is to spread more awareness of practicing compassionate care across clinical and school settings. And next, Patricia will introduce herself.
Hi, everyone. I'm Patricia Parker. I am our group's researcher. I live in Asheville, North Carolina. I'm in my 4th semester here at Ball State, and I have been in RBT for almost 3 years. I have previous experience working with adults with developmental disabilities in a group home setting for those with severe persistent mental illnesses. In my role as an RBT, I have worked in home, school, and community settings with learners ranging in age from 5 to 19. I am particularly interested in ABA reform and applying acceptance and commitment therapy as a lens for understanding my own ethical behavior with respect to how I relate to stakeholders, clients, and colleagues, and as a tool to teach my learners psychological flexibility.
Hi everyone, my name is Carrie and I currently live in Central Florida. I will be the fielder for this project, I'm in my 4th semester at Ball State as well, and I plan to graduate this summer. I've been in the field of ABA for 4 years and have worked in the home and clinic environments with clients aged 2 through 17. Throughout the last few years, I've seen the positive impacts effective collaboration between professionals can have on our clients. And on the contrary, I've also experienced the disarray that comes when professionals are unable to work cohesively. After becoming a BCBA, I look forward to applying the knowledge and tools I have gained for effective collaboration to help give my clients a better quality of life.
Hello, my name is Brooklyn Taylor. I will act as the illustrator for the presentation. I live in Indianapolis, Indiana, and I am on my final semester at Ball State. I've been an RBT for 3 years, and in my time as an RBT, I have worked predominantly in center, but I've worked in home as well. Most of my experience is with children ranging from ages 3 to 17, and at my current place of work, we put an emphasis on life skills for young children 7 and under.
Hi everyone, my name is Haley Wilcox. My role is the project's summarizer. I live in Clarksville, Tennessee, and I'm in my third semester in this program. I have been formally involved in the field of ABA since I was 15 and have a lifetime of experience thus far. I started working directly as a practitioner at the start of this program with a 22-year-old in his home. My interests in this field relate to employment for adults with developmental disabilities and one day in training and supervising new people working in this field to create a more competent and empowered group of practitioners. Next, Samantha will give an overview of this presentation.
Okay, I'm sharing screen, so I lost the mouse. Okay. All right. Thank you all for your introductions and sharing a little bit about yourself. Next, I will discuss the overview of the presentation. There are 3 research questions governing this presentation. First is what effects collaboration with other professionals have on the overall quality of ABA service provision. Next, we will talk about how do the practices of cultural competence, humility, and/or responsiveness relate to a BCBA's ethical responsibilities when engaging in collaboration. Last, what are some qualities that signal effective collaboration? Our debate is broken up into 3 sections and are as follows. We'll first talk about collaboration in ABA, including why it matters, benefits and potential barriers in ABA, including why it matters, benefits and potential barriers, and the different types. Next, we will discuss cultural competence, humility, and responsiveness, including distinguishing between these concepts, why each concept matters, and tools that can be used. Lastly, we will have our mock debate. 2 of our group members, Patricia and Haley, will play BCBA characters who are grounded in contrasting ethical frameworks and will respond to a case scenario according to the ways that those subjectivities inform their clinical lenses. Our hope for doing so will be to present differing perspectives on behavior analytics service provision, place the concepts in a real-world context, and illustrate the ethical responsibilities of the behavior analyst with respect to collaboration and cultural humility. Brooklyn will begin by discussing collaboration in ABA.
Thanks, Samantha. Sheridan and his colleague define collaboration as a form of co-labor that prioritizes interdependence and co-equality between 2 or more interested parties with common goals in a decision-making process affecting a service consumer, in this case, likely a child receiving behavioral support. To me, this means deriving a contract that outlines each of the roles, responsibilities, protocols, and structure for everyone's involvement. This will ensure that there is still clear independence of each discipline. However, each professional is able to contribute their expertise to the designated area that needs attention. Collaboration involves equality, which refers to willingness to listen to, respect, and learn from one another, parity, is that the word? Parity, which refers to the blending of knowledge, skills, and ideas to enhance the relationship and outcomes for children. The key is communication and simply understanding and being receptive to each of the disciplines involved. We will examine collaboration in greater depth later in this presentation when we describe the differences between multidisciplinary, interdisciplinary, and transdisciplinary approaches. Next, Haley will discuss why collaboration matters.
Thank you, Brooklyn. Collaboration is paramount for effective behavioral programming. Ineffective collaboration can impact a team's ability to provide interventions with fidelity. Just making sure I'm on the right slide. No, thank you. Also, Kelly in 2013 noted that clients may prefer a collaborative approach and that collaboration is desirable because it increases treatment integrity and maintenance of acquired skills. The BACP Code 2.10, Collaborating with Colleagues, states that behavior analysts collaborate with colleagues from their own and other professions in the best interest of clients and stakeholders. We regularly work alongside other professionals such as teachers, speech and language pathologists, occupational therapists, and other medical professionals. Being on the same page rather than at odds with these professionals, regardless of any differences we may have, is ultimately in the best interest of our clients. Next, Patricia will discuss the benefits of collaboration in ABA.
Thanks, Haley. Collaboration allows service providers to get a fuller picture of the client and their daily environments while working together to develop the most appropriate interventions. When collaboration is effective, educators, families, and outside service providers share in the responsibility for each learner's success. Through prioritizing collaboration, we can avoid placing blame on any one party for the failure of an intervention or strategy and instead focus on engaging in actions that maximize success by taking into account available resources, unique perspectives, and values of each interested party. And now Carrie will discuss any potential barriers we foresee with this process.
Thanks, Patricia, I'm sorry. So there are several potential barriers that may arise. The first we will discuss are conflicting ethical approaches. While there are many possible ethical frameworks that may inform the ways in which professionals practice, for the purposes of this presentation, we will be focusing on the following two. First, virtue ethics. As explained by Broadhead and colleagues, under a paradigm of virtue ethics, certain behaviors are good while others are considered bad. This framework deals in absolutes. Deontology, context is needed to determine what is good or bad. These distinctions are derived from other social norms rather than focusing on the formal properties of the behavior. And we will revisit this issue later in the mock debate portion of our presentation to illustrate how these differences may manifest in direct practice. Varying teaching methods and experience may be the next barrier. Collaboration with professionals who have various educational backgrounds and specialties creates the possibility of disagreeing philosophies and instructional approaches. In a situation where both treatments are evidence-based, Newhouse-Oyston found that they may be incompatible as one may cancel out the effects of another, or medications may detract from current motivation to participate in coping skills training. Differing views on restraint, seclusion, and other punishment-based procedures. Practicing professionals from several fields of study may have conflicting protocols for when or how to implement punishment-based procedures, or simply choose alternative methods to avoid these types of strategies entirely. As noted by Broadhead, if the client's team recommended for full inclusion in a public school setting and a member of an interdisciplinary team recommended the client has limited interaction with typically developing peers, this may interfere with the client's goals. Next, we'll talk about role boundary issues. Brown and colleagues warn that these issues may arise from poor understanding of each other's professional's role or when roles overlap, as when expertise is shared. A practical example of this would be a BCBA and a speech-language pathologist disagreeing on who is in charge of identifying and teaching a learner an alternative method of speaking. And now Brooke will share about our visual. Brooklyn.
So I'll talk about the types of collaboration. Castillo and colleagues delineate the following types of cross-disciplinary collaboration. The first being multidisciplinary, which is practitioners operate within the confines of their professional boundaries, each delivering treatment according to their discipline-specific view, and often to address a specific and separate deficit. This can obscure a broader understanding of the interplay of variables affecting client outcomes. The second type is interdisciplinary. Teams attempt to provide a more comprehensive and integrative approach to client care by combining and coordinating the expertise of participating professionals. This requires more frequent interactions, and professionals still work independently of each other to target goals that are developed collaboratively. The third type is transdisciplinary, which synthesizes the discipline-specific expertise of each team member by obscuring the boundaries that typically divide fields. It involves role expansion, which is working beyond the traditional confines of their traditional roles, or their individual roles, sorry, and role release, which is accepting shared responsibility. The figure on the slide, figure 1, represents analogies for each approach. The differences between each approach are emphasized, and the visuals will assist in greater understanding of these different approaches. To that end, multidisciplinary collaboration on the left is a salad where all components are together but distinct and separate. The interdisciplinary collaboration is a stew, so the components are more incorporated for the sake of the larger goal, but they continue to maintain their own character. In contrast to both, transdisciplinary, which is on the right, it involves all ingredients being fully incorporated, which represents obscured boundaries to serve a larger purpose, as with the pictured cake. Next, Patricia will explain the stakeholders and other professionals of concern.
Yes, so first of all, we have teachers. Their primary focus is on academic progress, as well as implementation of behavioral interventions in vivo, environmental factors specific to this context, and potential barriers to treatment. They hold a specific expertise in the resources available within the classroom setting and can provide indirect data as background and or assist in or conduct more direct assessment procedures for use by the BCBA. They also serve in a professional capacity as both collaborating partners and stakeholders who may help determine the direction of programming. Next, we have educational administrators. They are more about big picture thinking, compliance with IDEA, and the rights of the student and the family. Specialists such as speech, occupational therapy, physical therapy, clinical psych, etc., provide discipline-specific knowledge and perspectives. And then as a practical application of this process of collaboration, we can cite medical professionals. So when synthesizing the disparate perspectives for collaboration, healthcare professionals may help guide the process of needs identification, as discussed by Sheridan and Kurtachville, by emphasizing how medication may exacerbate certain skill deficits or interfere with acquisition of new skills. They may request behavioral documentation to fine-tune a pharmaceutical regimen. And this is just one particular example. While parents and caregivers are not technically other professionals, families are essential partners, not desirable extras, and they should therefore be factored into discussions of effective collaboration due to the bidirectional influence of school and home in determining learner outcomes. It's important to recognize that no setting exists in a vacuum. A learner's success in one setting is a strong predictor of their success in all others. So we have to take an integrative approach that takes into account this factor. And next, Haley will discuss some proactive steps and conflict resolution strategies for collaboration.
Thank you, Patricia. The BCBA can help facilitate continuity between settings by factoring in the views of all relevant professionals and stakeholders in order to choose interventions with high rates of social acceptability, then training all relevant personnel on said interventions to ensure fidelity. In the event there is a role boundary issue, as with the scenario previously discussed, comparing the relative strengths of each disciplinary approach may help identify opportunities for collaboration. Now Brooklyn will discuss this figure that we have here.
This visual represents one particular instance of the role overlap with another discipline, in this case, speech-language pathology. In the event of a role boundary issue with different professional modality, it would be to an advantage to do a similar inventory to more clearly delineate responsibilities. Next, Sam will discuss cultural competence, humility, and responsiveness.
Thank you all. Thank you all for sharing some great insight on what all entails collaboration in ABA. Next, we will discuss cultural competence, humility, and responsiveness, why each concept matters, and tools for engaging in culturally humble praxis. Haley will begin by elaborating more on cultural competence.
Thank you, Samantha. The term cultural competence can be traced to the work of Cross and colleagues in 1989. They define it as follows. Culture refers to integrated patterns of human behavior that include the language, thoughts, communications, actions, customs, beliefs, values, and institutions of racial, ethnic, religious, or social groups. Competence implies having the capacity to function effectively as an individual and an organization within the context of the cultural beliefs, behaviors, and needs presented by consumers and their communities. Culture can further be behaviorally conceptualized as a set of learning histories among a group of people or as behaviors that are passed from one person to another through imitation and modeling, as with cultural selectivism. By synthesizing these concepts, the goal is for professionals to demonstrate efficacy in interacting with people whose backgrounds are dissimilar from their own. A study from Pash Orlow in 2004 observed that culturally competent care reflects an ethical commitment to patient autonomy and justice. Brooklyn will now discuss this visual here on the left.
The visual from Bradshaw's research on culturally responsive early intervention services demonstrates some core objectives with respect to culturally competent service provision. Next, Patricia will discuss cultural humility.
Thanks, Brooklyn. So Patricia Wright defines cultural humility as it pertains to service provision and applied behavior analysis in the following ways. Cultural humility incorporates a lifelong commitment to self-evaluation and critique to address power imbalances and develop mutually beneficial and non-paternalistic partnerships with communities. It is meant to replace cultural competence because the term competence denotes acquisition of knowledge of other cultures as an end goal that can be mastered, whereas cultural humility recognizes and requires an ongoing lifelong trajectory. It is an introspective practice focused on self-knowledge as it pertains to the other. Example questions within this framework could be, how do my experiences differ from those of my clients and other individuals who serve them? How might those differences maintain certain inequities in quality of care? And what people or resources can I consult to make sure I am addressing the cultural needs of the people I work with and for? And now Brooklyn will present another visual.
This visual demonstrates the attributes necessary to engage in culturally humble praxis and the desirable consequences of doing so. That is, through displaying openness, self-awareness, and lack of ego, and by engaging in supportive interactions and self-reflection and critique, one may engage in the lifelong learning process that is cultural humility. Next, Carrie will discuss cultural responsiveness.
Thanks, Brooklyn. This concept was derived from educational practices. Miller and colleagues illustrate that cultural responsiveness places a strong emphasis on viewing cultural variations and differences as strengths rather than as needs that need accommodation. Cultural values and practices are to be woven into goals, curricula, and methods so as to contribute to the overall growth of both teachers and students as they learn from one another. Cultural responsiveness has been closely aligned with social justice in that a primary aim of responsive practice is to decrease educational disparities and increase success for oppressed populations. Cultural responsiveness may be represented in ABA service provision through reaching out to professionals of similar backgrounds to a specific client to collaborate on creating culturally significant materials if an individual's cultural experience is outside of one's scope of competence. And now Brooklyn will present another visual.
Figure 5 connects the historical context of ABA on the left, which is largely white, Western, authoritarian, and hegemonic, to its social justice-oriented initial aims, and puts those values into action through a new non-hierarchical approach on the right. This is an example of how a lens of cultural responsiveness can address injustices, past and present within our profession. Next, Haley will discuss why each concept matters.
Thank you, Brooklyn. Belu and colleagues in 2018 contend that ignored or unidentified cultural variables may become barriers to the delivery of effective treatment. Cultural humility can assist in identifying areas of weakness or lack of knowledge and experience that may hinder a behavior analyst from identifying these variables. As observed by Bowman and colleagues in 2021, communication failures are a common barrier to effective collaboration. There is a large body of research that focuses on how cross-cultural communication issues may affect client outcomes more directly. In one such example, Fong and colleagues note that a possible issue in cross-cultural behavioral health programming may be perceiving behaviors that are norms in other cultures as maladaptive. In addition, our individual positionalities also affect our ability to communicate and collaborate with other professionals. This is important to bear in mind because ineffective collaboration can lead to reduced trust in a care team and measurable harm to a client. Further, BACB Code 1.07 states, in part, behavior analysts actively engage in professional development activities to acquire knowledge and skills related to cultural responsiveness and diversity. They evaluate their own biases and ability to address the needs of individuals with diverse needs or backgrounds, included but not limited to age, disability, ethnicity, gender expression identity, immigration status, marital relationship status, national origin, race, religion, sexual orientation, and last but not least, socioeconomic status. With this in mind, we are fulfilling our duty to our profession by incorporating these principles and practices into the ways in which we interact with other professionals, clients, and stakeholders. Next, Brooklyn will share a visual for engaging in culturally humble praxis.
Thank you, Haley. This checklist demonstrates the importance of evaluating any biases that may be affecting a practitioner's openness to collaboration with professionals in other disciplines. As suggested by Miller and colleagues, using open-ended questions when collaborating with other professionals and stakeholders may reduce cultural blindness and facilitate meaningful engagement. Next, we will start the mock debate portion.
Okay, thank you guys for discussing the differences between cultural competence, humility, and responsiveness. The last portion of our debate will include our mock debate. Let's introduce the profiles of the BCBAs. Profile 1 is based on deontology, progressive, reform-minded, integrates cultural humility and responsiveness as primary clinical ethics. Patricia will represent BCBA 1. Relevant codes she will include are 1.10, awareness of personal biases and challenges, 2.10, collaborating with colleagues, and last, 1.07, cultural responsiveness and diversity. Profile 2 will be based on virtue ethics, focused on rigid adherence to ethics guidelines set forth by the BACB and other organizations relevant to our field. As discussed previously, a virtue ethics framework deals in absolutes of what actions are good or bad, and therefore struggles to consider ambiguities and context. Haley will represent BCBA 2. Relevant codes she will include are 2.01, providing effective treatment, 2.15, minimizing risk of behavior change interventions, 2.19, addressing conditions interfering with service delivery. All right, so let's present the case scenario. A client you have been providing home-based services for over a year is starting to receive services in the school setting. You have met his teacher at IEP meetings, but otherwise have not had a chance to establish rapport with her. When you go to the school for your first observation, you learn that the teacher routinely uses seclusion to deal with aggressive behaviors. In practice, this looks like placing the student of concern in an empty resource room for a minimum of 5 minutes with a school administrator outside and only allowing them to rejoin the class when they can demonstrate a calm body. You have a strong relationship with your client's parents, and they have never expressed concern about this teacher. However, they are fully aware and informed of the punishment procedures that are in place. You are also aware that because your client is non-vocal, they would likely not be alerted to any potentially concerning repercussions that he is experiencing in the classroom. Your client engages in high rates of aggression and consequently has likely been and will continue to be subjected to this intervention if you do not intervene, though you did not observe that during your initial assessment. How would each of you balance collaborating with this teacher against your responsibilities to the client? Patricia, let's start with you.
Thanks, Sam. Per code 1.10, awareness of personal biases and challenges, we have a responsibility to unpack our own assumptions about why a service provider would resort to using restrictive practices. My assumptions are as follows. This teacher may be lazy, cruel, looking for a quick fix, ableist, and perhaps even unqualified. In reality, she is likely overworked and underpaid, limited resources for training, which in turn, she has limited resources for training, which in turn creates knowledge deficits. She may be desperate for something that works. She has too many children to manage and keep safe. And this may engender an excessive focus on classroom management, sometimes at the expense of individual students' functional skills or progress. These are some questions that I ask myself when navigating this dilemma. First of all, what is my purpose in this setting? How do the assumptions that I already spoke about contradict my stated purpose? To that end, what unmet needs may have contributed to this teacher implementing such a restrictive intervention? What learning histories and contingencies of reinforcement might be maintaining those choices? Finally, how can I act most consistently with my own ethical values when responding to this teacher's behavior? Per code 2.10, collaborating with colleagues, a behavior analyst has a responsibility to act in their client's best interest when collaborating with persons from other professions and to identify and enact contextually appropriate compromises when doing so. My purpose is always to support my client. What that looks like in effect may sometimes seem counterintuitive. This is because stakeholders and other professionals who work with my client will likely be with him longer than me and will relate to him in different ways than I will. Recognizing that, the best way to provide support to my client may be at first indirect. While it may be easy to say that seclusion is always inappropriate and harmful, alienating this teacher will not ultimately allow me to collaborate effectively or meet my client's needs, both of which are my professional obligations. Even if my assumptions have some legitimacy in this situation, as the assumptions and the reality are not necessarily mutually exclusive, they ultimately do not matter because they don't allow me to serve my higher purpose. Sorry, one second. Even if, yes, so they preclude meaningful action. This teacher may feel judged and on edge by having a so-called expert on behavior in their class in the first place. If that is the case, it will serve as a significant barrier to effective collaboration and rapport building. This would only be exacerbated by taking an accusatory stance from the outset, identifying appropriate compromises next to impossible. Because I am in this setting to serve my client and act in his best interests, it is my responsibility to respect the teacher's domain, observe, collect data, and build rapport with her. When I feel that I have a reasonable understanding of maintaining variables in the environment that may be influencing this teacher's behavior, I will be better equipped to build rapport and provide productive suggestions. Investing time and effort into building trust and rapport will in turn make teacher generalization of any less restrictive intervention much more seamless in the long run. Per code 1.07, cultural responsiveness and diversity, it is our responsibility to evaluate how our cultural biases may interfere with our ability to provide services to people with diverse needs and backgrounds. To that end, when evaluating our relationship with this teacher, we must consider how their cultural beliefs about appropriate behavior management and the role of the student and the teacher, in this case, a very traditional hierarchical discipline-focused model, may inform their perspective on seclusion. We should also analyze how resource constraints may be informing their choices to employ a more restrictive practice. What resources might be needed to make a more client-centered choice of intervention. Finally, cultural humility dictates that we assess our own biases that may interfere with our ability to collaborate with others. We can put this self-knowledge into action by assuming best intent on the behalf of other professionals, then arranging the environment to maximize success for them, ultimately serving our clients much more effectively in the process. And now, Haley will rebut everything I just said.
Thank you, Patricia, for sharing. So how I would balance collaborating what we know from the scenario with this teacher against responsibilities to clients is as follows. Per core principle 1, benefit others, we have a responsibility to protect the welfare and rights of clients above all others. Actively identifying potential and actual conflicts of interest and working to resolve them in a manner that avoids or minimizes harm is one way to go about it. Another is actively identifying and addressing factors that might lead to conflicts of interest, misuse of their position, or negative impacts on their professional activities. Further, I effectively and respectfully plan to collaborate with others in the best interest of those with whom they work and always place the client's interests first. Further, for core principle 2, treat others with compassion, dignity, and respect, we must behave towards others with those attributes. We must acknowledge that personal choice and service delivery is important by providing clients and stakeholders with needed information to make informed choices about services. Per code 1.02, conforming with legal and professional requirements, we have a responsibility to follow the requirements of both the law and our professional community. According to the ABAI in 2011, a form treatment team should be informed by the research literature and should determine that any procedure in that person's best interests. These interests must take precedence over the broader agendas of institutions or organizations that would prohibit certain procedures regardless of the individual's needs. A core value of the ABAI with regard to behavioral treatment is that welfare of the individual being served is the absolute highest priority. Further, the ABAI strongly opposes the inappropriate or unnecessary use of seclusion, restraint, or other intrusive interventions unless a rare occasion warrants those procedures. And as far as we know in this scenario, it isn't warranted, as far as we know. Per Code 2.01, providing effective treatment, we prioritize clients' needs and rights in service delivery. Seclusion is not conceptually consistent with behavioral principles, is not based on scientific evidence per educational literature, and is designed to maximize desired outcomes for and protect all clients from harm. Further, per Code 2.10, collaborating with colleagues, we collaborate with colleagues from their own and other professions in the best interests of clients and stakeholders. I could not ethically work with someone who could very well be actively harming my client by secluding him. I know it may be my responsibility to do whatever possible to collaborate with this teacher to maximize outcomes with my client, but in good faith, I cannot. This teacher violates many of our ethical principles, and although this educator does not work in our field under the jurisdiction of our ethical principles and codes, I would be violating these ethics by proxy through collaboration. Per Code 1.09, non-harassment, my ethical obligation to halt any seclusion practices could be misconstrued as harassment towards the educator I am expected to collaborate with. This may seem dramatic to claim it as non-harassment, but it could appear so. It would be my responsibility to rectify the situation by implementing a behavior intervention plan that would aim to reduce the client's aggressive behaviors. But this would require that the teacher let me create a plan that would not include seclusion. I cannot risk losing placement in this school for other clients I may work with in the future, and think it would likely be best to remove myself from this situation and notify the parents of what I've seen. Alienating the teacher would appear to be harassment, and I cannot put myself in any situation like this. Next, Brooklyn will share a visual.
Here we have Figure 7, a flowchart representing a decision-making model for evaluating non-behavioral treatments. Would each of you like to respond to this model? We'll start with Patricia.
Thanks, Brooklyn. So per this visual, seclusion does represent a risk to client safety. As such, it rises to a level worthy of concern for me. What is at issue here is not whether using seclusion is right or wrong, as we already know that punishment-based procedures should only be utilized after reinforcement-based protocols have been exhausted and or proven ineffective, and that seclusion in itself can traumatize children or otherwise endanger their safety. It is not a solution, full stop. It does not have my support. My concern is not with this practice, but instead with how I can approach supporting and collaborating with this teacher to find a viable functional alternative. My approach to this is to be curious and compassionate instead of judgmental. In practice, this looks like remaining neutral regarding practices currently in place unless explicitly asked, and employing open-ended questions in addition to direct assessment in order to ascertain what unmet needs may exist for this teacher. It is possible that lending her appropriate support will have collateral effects on my client's behavior, even in absence of direct intervention. Haley, do you have any thoughts?
Yes, thank you, Patricia. Seclusion is a non-behavioral treatment that our field is strictly against. The client is at risk of becoming more aggressive and destructive and is at risk of developing serious mental health disorders. Due to personal research after viewing the ABAI's statement discouraging any use of seclusion or restraint, I am familiar enough with this practice to understand that it is possible when translated into behavioral principles. However, I am uncomfortable with translating these procedures into something more ethical because this feels outside of my scope of competence and practice. I do not want to inadvertently allow the client to continue to be in harm's way whilst working through the process of rectifying this procedure. Next, we will move into our Q&A session.
Thank you both for your statements. Do either of you have any questions for each other?
Yeah, I have a question for Haley. Hi. It sounds like your reservations about collaboration with this teacher are grounded in your ethical principles, which I think is wonderful. What I'm not hearing from you are what steps you will take to appropriately support your client in the setting where he has to be, as we have very little control over that aspect of his case. What concrete ideas do you have for this case study beyond refusing to work with the educator in question unless she meets your demands? Additionally, how are you factoring our responsibility to incorporate cultural responsiveness and considerations of diversity per code 1.07 into your responses to this teacher's behavior?
That's a great question, Patricia. I wouldn't say that I'm refusing to work with this educator until my demands are met. Rather, I do not find myself comfortable collaborating with someone who's participating in a practice that our field is vocally opposed to. In this case, I would find myself in a situation where my scope of competence is not enough to provide the services my client would need. In regard to your question about Code 1.07 and factoring in cultural responsiveness and considerations of diversity, I wouldn't say that I'm really discriminating against or making assumptions about the teacher in question. To me, this person is just another educator trying to do her job. But what I cannot tolerate is someone putting my client in harm's way, regardless of who this person may be as a whole. It is also this person's responsibility to know and understand that seclusion is wrong and avoid it at all costs.
Thanks for that thoughtful answer, Haley.
Now, I have a question for you, Patricia. As you shared, you realize that seclusion poses a risk to client safety. Because you acknowledge this and choose through this with this educator in question, how do you reconcile working with a professional who employs a practice that you know traumatizes students? Especially since the client is nonverbal, how do you reconcile this situation?
That's an excellent question, Haley, and it's something I ask myself quite frequently as well. I believe that it is my responsibility to work within the parameters of the environment that I am contracted to address, even and perhaps especially if it makes me feel uncomfortable. If I divest and try to find someone else to address these concerns, they will surely hold the same reservations as you and I. So, what would doing so accomplish other than to absolve me of my sense of mutual implication? I am more interested in identifying how I can change the contingencies in the environment so this teacher does not see a need to implement restrictive practices. Employing seclusion to address aggressive behaviors is not a best practice, and it certainly isn't ethical, but it is also not illegal, and it is currently being condoned by the family. So without lending my support to this teacher, it will likely continue in perpetuity. Regardless of how I respond, I have no control over who is teaching my client. So it will ultimately be to his advantage to have someone who is willing to confront this discomfort and cognitive dissonance in order to advocate for him.
Thank you both for your perspectives. Moving on from the mock debate portion of our presentation, we have a couple more questions. Speaking more broadly regarding collaboration with other professionals, does anyone have any related personal experiences that they would like to share?
Sure, yeah, thank you, Carrie. As I mentioned in my bio, I've experienced as an RBT in both a clinical setting and a school setting. Although I have only been in my new position for a few months, I very quickly gained a much greater understanding of both the reward that occurs when collaboration is apparent, but also why collaboration can be difficult when there are opposing opinions to certain concepts. The most valuable lesson that I've learned is how important clear, direct communication is when working with professionals across different fields. It leaves no room for confusion or misunderstandings. It also ensures all professionals are included in important changes with the client, such as attending IEP meetings. I feel compelled to spread more awareness of ABA because there is a lack of understanding of how it's practiced in the school system and in the community in general.
All right, now I will wrap up this presentation. First, I want to reiterate the importance of collaboration. Overall, with collaboration, you will see improvement of workplace environments, therefore allowing more efficacious treatment. It presents the opportunity to learn from one another. Effective collaboration yields best results for clients across several professional domains. And also collaboration is prioritized by ethics codes and core principles. So either way, collaboration is part of our field. Now some strategies for effectively collaborating. It is important to work together with mutual respect and shared values, to acknowledge team members' roles and abilities, communicate in a manner that supports a team approach, and apply team building values and principles. And to finish this off, I want to revisit the importance of culture, humility, and responsiveness in our daily practice. First, cultural humility gives us a better understanding as to who the people we work with are as a whole, and thus allows us to treat and work alongside others as a whole altogether. Further, cultural responsiveness can help us teach others in ways that are meaningful and relevant to them. So either way, cultural humility and responsiveness are important for collaboration, and they should always be considered. Does anyone have anything to add before we close out?
I was just going to say, if any of the audience has any questions about collaboration or needs any further resources, we can direct you to our works cited. So just reach out to any of us. Yeah, there are references, but we can send them, like, or if you have specific questions, we can point you toward resources. And that's it.
Great. Thank you, Patricia. Thank you, everyone.